Ask Ms. Shackley to please call the roll.
Van Mitchell. Dr. Gerard Anderson.
Here.
Thank you. Dr. Joseph Levy.
Here.
Thank you. Dr. Aberi Anukuga.
Here.
Thank you. Dr. Stephen Rockhour.
I'm here.
Dr. Anukuga, we have quorum.
Okay, great. Thank you very much. First, welcome everyone. Would like to thank you all for your interest and time today in joining us. First, would like to note that the board is working with a revised agenda. That agenda is available online on our website and was posted on January 22nd. The board will not be making any preliminary affordability challenge determinations at this meeting, and that is reflected in our revised agenda. So with the agenda in front of us, we'll move on to agenda item number 2, which is to approve our minutes from November 25th, 2024 meeting. Is there a motion to approve these minutes?
So moved, Jerry.
Second.
Thank you.
Rockhour.
Thank you. Any discussion of the minutes as drafted? Hearing none, I call for a vote then to approve the minutes as drafted. All in favor say aye.
Aye.
Okay. All opposed? The ayes have it. The minutes are approved. Thank you. And then we'll move on to our third agenda item, which is our public comment. Did the board receive any written comments? Let's start with that.
Yes, the board received 4 written comments which were shared with the board and posted to the website.
Okay, thank you, Christina. And any requests for public comment at today's meeting?
Yes, we have 4 people registered to provide oral public comment today. Each commenter will have 1 minute and 30 seconds to speak. Commenters will be called on alphabetically. Once I call on you, please state your name, the organization, agency, employer, or any other entity which you are affiliated with, if any, or whether you're a consumer, and the agenda item that you would like to address. And then we can begin the timer for your comment. I'm going to let Sydney pull the timer up, and then I will call on our first participant. Janie Abernathy, are you here?
Yes, I'm here.
Yes, just please state the name, your name, the organization, agency, employer, or entity that you're with, if any. And then we can.
My name's Dr. Janie Abernathy, and I'm a primary care doctor practicing in an academic center in Southeast Baltimore.
And I'm sorry, the agenda item that you're going to be speaking to today.
The commenting on the cost of Jardiance and Farxiga.
Great. You may begin.
Thank you so much for having me. With permission, I am here to share the story of my patient that would have benefited from lowering the cost of Farxiga or Jardiance. I've cared for her since the first year I became an attending clinician. She's a third generation Dundalk resident who comes to an appointment with me every few months for management of her diabetes, heart, and kidney disease. And my close relationship with her is why I consider my job such an incredible privilege. I've attempted to order her an SGLT2 inhibitor multiple times over the past few years. She's enrolled in Medicare and has Medicare Part D. When our care team first attempted to get her this medication in 2021 with insurance, the medication cost $130 per month. And on a fixed income with multiple other medication copays, this was really untenable. We came up with a workaround care plan that was high quality, but ultimately inferior, requiring us to prescribe multiple medications to fill the role that perhaps one SGLT2 inhibitor tablet could have performed. I am among many clinicians who see SGLT2 inhibitors as a true breakthrough in pharmacotherapy. They have been studied in at least 15 large-scale clinical outcome trials, including over 100,000 patients, and they have amazing outcomes. My patient's kidney disease has worsened such that this medication class really would no longer be safe for her to take. We've missed her window, and as we prepare her for dialysis, it really distresses me to think that her financial situation impacted her care. I am grateful that you're taking up this important issue. Thank you.
Thank you. We appreciate your comments. Leonard Lucci, are you here?
Yes.
Okay.
My name is Len Lucci. I reside in Bowie, Maryland, and I, for the past 5 years, have been prescribed Jardiance. And I go to the giant pharmacy every 3 months to pick up my Jardiance, and each time the pharmacist pulls me aside and points to a piece of paper and says, "This is how much it's going to cost. Or do you still want to get it?" And I'm always saying the same thing. Of course I'm going to get it. I'm a diabetic. I need the medicine to keep my blood sugar down. And each time they always say, "Well, you know, there are plenty of people who do not pick up their medicine. When they see how much it is, they do not pick it up." And that just happens every time. And then just late last year, the pharmacist was upset. And I said, "What's the matter?" He says, "Well, the one gentleman who doesn't pick up his medicine and he keeps coming in by and hoping it's cheaper, finally he passed away because of diabetic complications." And so, you know, I'm fortunate that I'm able to pay these exorbitant costs, but plenty of people just have to make the decision between the medication and then the food at the grocery store, and that's just a very regrettable thing. That's my testimony.
Thank you very much. Okay, next we have Peter Maybarduk. And just a reminder, please state your name, the organization, agency, employer, or any entity if you're affiliated with any, and then the agenda item that you would like to address, and we will begin the comments. Mr. Maybarduk, are you here?
Yes, I'm here. I'm prepared.
Okay. And sorry, you can state your name.
Thank you. Yeah, Public Citizen is a national consumer group with 500,000 supporters. I'm here to address the cost of Jardiance and Farxiga. For 50 years, we've stood for the public interest before agencies, Congress, and the courts. So we commend the work of the board making medicine more affordable. Drug maker price abuse contributes to an epidemic of treatment rationing. Nearly 1 in 3 Americans has failed to take treatment as prescribed due to its cost. The outrageously high prices of Jardiance and Farxiga do not come from R&D costs. Drug makers, swaddled in monopoly patent protection, simply charge the most their public programs will pay, meaning it's not only responsible but essential that public programs set limits on what they will pay. Specifically for Jardiance and Farxiga, both drugs have made more than $20 billion each so far, and made back more than 30 times the average R&D cost of a new drug. The R&D costs of these specific drugs are kept secret by AstraZeneca and Lilly, so we can't evaluate. Both drugs are priced more than 10 times higher to Americans at list than to people in other countries. Both drugs benefited from more than $400 million of taxpayer support for basic and applied research. Lilly spends more than $1 billion a year on advertising. For the most recent data we have, that was more than Maryland spent on all Medicaid drugs combined for a year. Both spent billions enriching themselves last year through buybacks, dividends, and executive compensation. The idea that these companies cannot afford to offer Maryland a reasonable price is preposterous. We encourage you to move forward with the payment limits. Marylanders need the money more than these pharmaceutical companies. Thank you.
Thank you. Thank you for your comment. Tiffany Westrich Robertson. Tiffany Westrich Robertson, are you here today? Since I am not hearing our final participant, that concludes the public comment for today.
Thank you, Christina. And I don't see the individual among the participants. So we'll move on to our next agenda item. We have a couple of topics underneath the cost review. First, we'll talk about the final action amendments to COMAR. I believe the staff has a presentation on the proposed action and comments. Dr. York, I will turn it over to you.
Great, thank you, Dr. Onukwuga. Sydney, are you able to pull up the presentation on the final action? Yes, that's it, perfect. So in today's meeting, we are asking for final action on the amendments to the cost review study 1401-0405. Sydney, if you go to the next slide. Great, thank you. So just as a reminder of the history of these regulations, the board proposed these amended regulations approved the proposed amended regulations in the September 10th meeting in 2024. Those regulations were then published in the November 1, 2024 Maryland Register, and comments were accepted through December 2nd, 2024. There were 3 comment letters that were received and shared with the board and have been are shared on our website. And it's worth noting that these regulations were also approved as emergency regulations with an effective date of November 14th, 2024. In this presentation, we're just going to go through the proposed regulations, showing the amendments that were made, or the amendments that were proposed, and then address each of the different comments that came in. I think one thing I would note as I begin this process, the comment letters were very robust, so we very much appreciated the comments that were submitted. Some of the comments weren't directly addressing the regulations that were under the proposed amendments. So we don't in this presentation address comments that were kind of outside of the scope of the regulations and the proposed amendments. But those, we do recommend reading those comment letters just so you can kind of get an understanding of the comments that were unrelated to these regulations. Sandy, if you want to go to the next slide. So the amendments had 3 primary changes that fit into 3 categories. One was clarifying different analyses and data sources that the board staff can use and provide to the board for the purposes of the cost review study. 2, the amendments included additional factors that the board could consider in the cost review study process. And then finally, 3, we made an update to align with the upper payment limit action plan that was that we were working on in the fall, and it created a step for a preliminary determination that a drug has or will lead to an affordability challenge, and then identify the circumstances of that affordability challenge. And that, again, aligns with the approval of the upper payment limit action plan that allows kind of a next step after the board makes that determination. Next slide. So I'm just going to go very briefly through the different amended changes. So the standard text is what the current regulation is, and the italics are a new language for proposed amendments, and the parentheses are deleting the language. So that's how you read these. So in terms of clarifying the analyses and data, you can see that we're adding the language of the board being allowed to consider data derived from any other databases containing relevant information. You can also see that we added reports from state governmental entities, and then also added a criteria of data derived from quantitative and qualitative data collected by board staff. So this allows the board staff to do kind of the additional analysis. Next slide. So again, we received 3 comment letters. 2 of those commenters stated that the amendment to the additional databases, so any database containing relevant information, and then also quantitative and qualitative data used by the board staff, failed to basically provide specific databases and data to be used. And then also 2 commenters objected to the reports being generated by state governmental entities to allow other state reports. We carefully considered those comments, but did not see a need to make changes to the regulations. If the board has questions on, exactly what that would be, exactly what issues came up, we're happy to share that. But I think at a high level, both of these changes were made based on, as we were going through the preparations for the cost review study process, just understanding that there were additional data sources that weren't necessarily covered in the original amendment language. So this does expand it just to allow for staff to review relevant data and information. Next slide. In terms of the factors considered in the cost review study process, the original therapeutic alternative factors that you were allowed to consider were included a lot of pricing information, but didn't necessarily include the utilization costs and out-of-pocket costs for therapeutic alternatives. So that was added in the amended regulations. And then in terms of patient access, we added some clarifying language on ensuring that we were focusing on patient assistance programs for the drug product under review and the policy surrounding and implementing such programs. So ensuring that it wasn't an ask of like all patient access programs for all of their products, but specifically the metrics and policies of the patient assistance program for the product under review. Next slide. We also clarified the language on the number of pharmaceutical equivalents, the therapeutically equivalent drugs. So again, basically the number of generic manufacturers. And then also provided additional language around the analysis of the market context of the prescription drug product, including lifecycle management, patent management, regulatory exclusivities, and then product hopping. We clarified that term. Next slide. And then in G, we added 3 additional board factors. One is the utilization and pricing of therapeutically equivalent drug products. Again, this allows you to compare to generic products. Analysis of the impact of state and federal regulatory and compliance issues related to prescription drug products. So this allows us to consider certain features and regulatory issues outside of prescription drug pricing. So it allows us to give a full context of the drug itself. And then also input from state and local government entities and the entities contractors such as health plan and health administrators. So those are additional factors that you can consider. And then finally, next slide, Sydney. The impact of utilization and spending for the prescription drug product on public budgets in comparison to the spending of the product to specific benchmarks. And then analyses and research including literature reviews by board staff in response to information submitted under Regulation 04 of this chapter or through any public comment or public procedure. If you go to the next slide. So overall, the commenters noted that the level of detail to use and describe different factors would recommend higher levels of detail and more specificity on certain factors. For example, also there were questions about the level of detail and how different factors will be weighed, patient access programs on the different factors. So like, again, how would the board consider patient access programs, impact on public budgets, impact on federal and state and regulatory and compliance issues, market context and literature reviews. And this has been an issue that the board has discussed, I think, in a number of meetings, including the establishment of these regulations. And the board's discussion reflected that different drugs and different market failures and specific drug situations for certain specific drugs will have different factors that indicate and allow the board to make any kind of determination that the board is going to make. So there's different market situations that may make a drug unaffordable, and the board wants to be able to consider all of those situations and not on the front end prescribe which situations kind of make that indication. Specific to the therapeutic alternatives, commenters identified a lack of clarity regarding how therapeutic alternatives are considered and related to data. And then one commenter stated that the consideration of the therapeutic alternatives should be based only on clinical appropriateness and not consider the cost of the therapies or other drugs. The feedback on the process for developing therapeutic alternatives, the therapeutic alternative list, has received a lot of comment. You'll remember that when we published the original regulations, there was a lot of questions, and then also requests for clarity on the therapeutic alternative process. So I think that's something that we'll continue to refine over time. However, I think the way that we work through the process for this first round of cost reviews and what we've communicated with everyone is basically that the list of therapeutic alternatives that were published and approved by the board are the therapies that are basically in the same line of therapy for each of the indications. And on the front end, we did not make any specific judgments on things like interchangeability or appropriateness or comparative effectiveness. And that process happens throughout the cost review study process. So for example, as we conducted these cost review study processes, you can the staff may, based on data, identify that certain therapeutic alternatives that are a subset of what was approved by the board are, most important or most reflective for comparison. So that's something that actually happens as part of the cost review process rather than on the front end. So just clarifying that for the board and listeners. Next slide. One commenter requested the removal of product hopping, and staff doesn't feel strongly on this issue. It's a well-used term that I think folks understand, but it is kind of a colloquial term that describes a series of specific behaviors. And if the board would like, we can not categorize them as product copy and just kind of describe the behaviors themselves. But this time the staff does not necessarily recommend removing that term. Again, the board may decide otherwise. Also, the analysis of the impact of state and federal regulatory compliance on issues on the drug. One commenter perceived this to expand the board's role to cover compliance with all federal and state laws relating to prescription drugs. Just as an example, so this basically allows the board to, I think would want to clarify that the intent of this provision is to allow the board to understand all federal and state regulatory circumstances that may be causing the environment and situation that may be driving the drug's affordability challenges. The board may remember that one of the drugs that they had referred to the stakeholder council for input, for example, had shortage issues that were based on, federal C2 regulations on ingredients, right? And if you want to be able to consider that kind of information formally as part of the cost review study process, you need to make sure that it's included in the regulations here. So that's why that term that provision is included. And then finally, one commenter recommended that the board consider out-of-pocket costs for patients and the patient experience, and emphasize considering the value of manufacturer discount programs, offsets, and the impact of benefit design on out-of-pocket costs. And I think that the board has indicated this in their communications, that this currently is being captured as much as the information is available. So this is something that is requested from different stakeholder groups through the request for information process. And as much as that information is available, that will be included in the data and analyses that the board can consider. And we would recommend that the board, take those into account as you do your cost review studies. Finally, there's thank you, Sydney. Next slide. Finally, the last change that we made was the preliminary determination. So again, based on our previous way that the regulations were previously written to reflect the statute that allowed you to do the cost review study. And the final step of that cost review study was for the board to make their determination of if the drug causes affordability challenges, led or will lead to affordability challenges to through high out-of-pocket costs or high costs to the state healthcare system. What the upper payment limit action plan proposes is that there is a preliminary step where you take the information that's available, and then if you, as part of that preliminary step, determine that the drug causes an affordability challenge, this then opens up the next step in the process, which is our policy review process, which we've talked about significantly over time. And we'll be, again, providing an update later in this presentation. But this preliminary step is important because it basically is the trigger for the next work in terms of identifying solutions to the affordability challenges that you've identified. So if you go to the next slide, Sydney, this just articulates exactly how you'll go about making that preliminary determination. And it clarifies that this is a non-final determination and subject to revision and modification. So the board ultimately will publish a final report. And if you gather additional information through the policy review process, you may change your determination on if the drug causes an affordability challenge there. Next slide. And this is again just the, up one more. So this is just the process that we'll follow in terms of publishing the preliminary determination. And this will provide a document that the public can provide input and feedback on. And then if you go to the next slide, Sydney, finally, the regulations require that we identify the circumstances under which the prescription drug product will lead to an affordability challenge to the state healthcare system or high out-of-pocket cost to patients. And again, that's the determination that you need to make under the statute. Next slide. And then we also put in the process for the actual final process. So again, we implemented this preliminary determination, which is non-final and allows us to continue our work through the policy review process. And then ultimately, once that process is done, the board will make a final determination concerning the affordability challenge and final cost review study report. Next slide. So we, out of the 3 comment letters that we received, one commenter expressed the view that the board is not authorized to make a bifurcated affordability determination, one for state and local government entity utilization, and then a separate one for all other utilization. I think we were trying to understand where this comment came from. The way that the process is meant to work is that the cost review is for the full state. And our reading of the statute that says the state healthcare system does not say, state and local government entities. It's for the entire state. So we are looking at data and information, getting patient input from all Maryland residents and looking at utilization data across the state. So when the board makes their preliminary determination, it is based on that data. So there is no bifurcated determination for different patient populations. It's just one for all Marylanders. And then once you move to the policy review process, one of the tools that you have is setting up repayment limits for state and local government. But it's almost like a separate issue there. We were also trying to determine if the bifurcation that was referred to was the fact that you can deem a drug to be unaffordable or cause affordability challenges because of high cost to the healthcare system or high out-of-pocket costs for patients. And that's just how the statute is designed. So I don't think we have necessarily a response to that. I think the statute allows you to deem a drug to cause affordability challenges for either of those 2 scenarios, basically. So that's the staff response on that. And based on our analysis, we don't recommend a change. And then finally, one commenter requested a fixed 60-day period to comment on the draft of the cost review study report and more specificity regarding on how the preliminary determination is made. I think we defer to the board on fixed periods of time, though our attention is always to try to make drafts of different data and information available for public comment that the board can assess the public comment at the same time that they're looking at drafts. And then the specificity on the preliminary determination, how it's made, we're hoping that is articulated as the board articulates the circumstance sorry, I'm going to my language, the circumstances in which the prescription drug has led or will lead to an affordability challenge. So that's again just saying that the board needs to provide that specificity as you make that preliminary determination. So I think we we agree with this commenter on the specificity is important. So with that, if you go to the next slide, staff recommends adopting the amendments to COMAR 1401-05-0405 cost review study as final with no substantive changes.
Thank you, Dr. York. We received these comments and appreciate the staff's time in developing this presentation, along with the statement of final recommendation. Is there a motion then to adopt as final the proposed amendments to Comar 1401-0405 cost review study as published in the November 1st, 2024 issue of the Maryland Register?
So moved.
Second.
Thank you. Any discussion on this motion?
Andy, I had a quick question. Recently, the federal government published some reports that were explaining the rationale behind the prices that were achieved in the Medicare drug price negotiation program. And I don't think that was a document that was specifically called out in our list of documents we could consider, but we do call out, we can consider different quantitative and qualitative information. Is that the type of report that we could consider per the regulation and these changes or not? I just wanted some clarity on that.
Michelle, did you want?
Dr. Levy, your lawyer would be happy to provide you with some legal advice, but not in a public meeting regarding how we interpret our regulation.
Okay.
Okay, thank you. Any other questions, comments on the motion? Right, if no further discussion, I'll call for the vote. All in favor, say aye.
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 All opposed, say nay. All right, the ayes have it. The motion passes and the amendments are adopted as final. Thank you. So we'll move on to agenda item number 5 on the cost review study. We have a couple of parts to this. First, beginning with a staff presentation for which I'll turn over to Dr. York. And then after that, we will move into closed session. Let me first begin with the presentation. Dr.
Great.
York, please proceed.
Yeah, thank you, Dr. Nokwe. This will be a brief verbal presentation and update. So as you know, we've been conducting the cost review on 4 drugs that have gone through the RFI process, as well as some background research on the other 2 drugs. And the 2 drugs that we're furthest along on are Farxiga and Jardiance. So the intention is to publish documents and make them available for public review and input before they come to the board. So we intend to publish what we're basically calling our dossier, which is all the analyses and data elements that the staff have reviewed and provided to the board, as well as staff analysis of how to interpret that data. So we wanted to make sure that the public does have the opportunity to review that document and provide input before the board kind of takes any action on it. So our intention is to publish as soon as possible, hopefully in the next, I don't want to put a specific time on it, but the next couple weeks. The documents are very close to final. We do need some approval and guidance in terms of exactly what underlying data we're allowed to publish publicly, just from the entities that handle that data and are responsible for that. So we're kind of going through the final steps of that process, and then we'll publish that information as soon as possible. And then when we do that, we will send a notification out to the public through our blast email system, as well as publishing it on our website. And we do intend to put a deadline for public input that you will then be able to consider. In terms of dates that we're looking at, we do have a stakeholder council meeting scheduled at the end of February. So we're looking at seeing if there's any way we can align with that in terms of trying to get public feedback and input. Just to provide an update, the data, we want to make sure that we're publishing kind of the raw analyses of the, just specific response of to each of the different criteria and elements that the board's allowed to consider out of your regulations, and then as well as the actual staff kind of analysis and interpretation of that data. So we, have a lot of work to do in the next few months. Especially around the cost review study process and the policy review process that's currently sitting as a proposed regulation. So We will keep folks updated, and the board may determine that they may want to schedule ad hoc meetings to make sure that some of the work gets done. So I did just want to flag that for the board. I don't think we have specific dates and times at this point, but we are working as quickly as we can, and very much look forward to public feedback on the data that we're able to publish. So that's our update. If you would like to move to the next agenda item, or I'm happy to answer any questions from the board as well.
Thank you for that. It's duly noted, the timelines, particularly for the council meetings. I think you'd mentioned stakeholder council end of next month. And then for board members, our next meeting is 3/24. So
Correct. Yep.
we'll definitely be considering ad hoc meetings as a way to keep things moving forward. Okay, thank you. So the agenda does reflect that the board is scheduled to move to a closed session, and that the purpose of that closed session is to receive legal advice. Now I will ask if there's a motion to close this session under the general provisions of 3-305B7 for the purpose of receiving legal advice from counsel and maintain confidentiality and attorney-client privilege in closed session. Is there a motion to close this session?
So moved.
Second.
Thank you. Any discussion on the motion? Hearing none, I call for a vote. All in favor, say aye.
Aye.
Okay, all opposed? The ayes have it. The motion carries and the board will now move to closed session. What that means then for the board members is we will be moving into a breakout room. Everyone else attending will stay in the main Zoom session. And so I ask board members to keep an eye out for that breakout room invitation. There is one remaining agenda item following the closed session. And so we will reconvene in open session upon completion of the closed session. Double checking that all board members are back. I do see everyone. Great. So our next agenda item and final agenda item is administrative update. And for that, I will turn it over to Dr. York.
Sorry about that. My computer was frozen. So we just have a couple administrative updates, and I alluded to a lot of them earlier in the presentation. But just wanted to reiterate that we have a series of regulations, proposed regulations that are currently in the Maryland Register and accepting public comment. And that's on our policy review process. For more information, please visit our website or go through the register. The comments are due, I believe, on February 10th, 2025. And another date to just keep in mind is that we have our next scheduled stakeholder council meeting on February 24th, and then the next regularly scheduled board meeting on March 24th, 2025. The only reason I flag all three of these kind of timelines is that the board may want to meet, schedule ad hoc meetings. The board may want to meet to review and discuss the comments received for the policy review process regulations. And then also if there's any work that the board wants to do on the cost review process based on the documents that we publish and the public feedback that we receive, the board may decide to schedule ad hoc meetings. So if the board were to schedule any ad hoc meetings, we would make sure that we would, again, send an announcement through email as well as publish on our website. So just letting the public know to keep an eye out for that. Next, I wanted to turn it over to Christina for a legislative update.
Thank you. The 2024 legislative session is well underway. PDAB had the pleasure of giving briefings to the Senate Finance Committee on January 9th and House Health and Government Operations on January 15th. We provided feedback to some excellent questions and obtained some information on how to improve for the future. There are a number of bills related to healthcare and prescription drug affordability. The PDAB is tracking about 15 bills that are related to our work. We will provide a legislative tracker to board members of potentially relevant bills throughout the session. Lastly, one bill that is worth flagging as directly relevant to our work is House Bill 424, and it's cross-filed as Senate Bill 357. This is the Prescription Drug Affordability Board Authority for Upper Payment Limits, the Lowering Prescription Drug Costs for All Marylanders Now Act. This bill is similar to the bill that was introduced in the 2024 session and creates a process for the board to set upper payment limits for payers in Maryland after the board successfully implements upper payment limits for state and local government. We provided technical assistance and input on the bill last year, and we expect that staff can provide the same technical assistance and input on these versions of the bill this year. Hearing for both of these bills will be on February 6th in Senate Finance and House Health and Government Operations. And that concludes my legislative update.
Thanks, Christina and Andy. Does that conclude as well the administrative updates?
Yes, that concludes the administrative update from staff.
Okay. Thank you both. So we are at adjournment. With that, I will ask if there's a motion to adjourn.
So moved.
Thank you, Jerry.
Second.
Thank you, Stephen. All in favor, say aye.
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 Thank you all. And with that, our PDAB meeting stands adjourned at 3:10 p.m.
Very great.